Good afternoon, everyone, and thanks for joining in today. I'm Dr. Kim Newell-Green, and I will be the moderator for today's virtual Grand Rounds COVID-19 vaccine update. I'll first remind you of the logistics of this speaker series. We'll go ahead and take a look at our speaker disclosures. I'll give you a minute for that. And then I'll just remind you that CME is being provided today. And so you'll be sent a survey after the completion of the webinar where you can attest to attendance, and you have to complete that in order to get your CME. Upon completion of the survey, we'll send out your certificates. Now we can look at the goals of our webinar for today. We can move forward. So our hope is that you'll be able to discuss and disseminate information on the current state of vaccine development. You should be able to describe California's plan for dissemination in anticipation of one or more vaccines and counsel patients about their potential fears and misunderstandings that they may have about vaccination. And vaccines and vaccination seems like a particularly timely topic. All COVID-19 topics have been very timely in these last 6 or so months. And this update on vaccines is no exception, especially after a very exciting couple of weeks. The results of the election have given us some insight into how COVID might be managed in 2021. And just yesterday, we heard news from the vaccine front that at least one vaccine has been preliminarily shown to be effective. And so I'm particularly excited to be here today with some amazing experts to talk us through the details of what is happening as we proceed towards a COVID-19 vaccine. This vaccine, as we all know, is being developed on an unprecedented timeline and also in a time of unprecedented questioning of science and institutions, of industry in general, and pharmaceutical companies in particular. The list of questions that we have as clinicians and as citizens is long. When will a vaccine be available? What type of vaccine will work? How well will any vaccine work? And we know that just developing an effective vaccine doesn't solve the problem. It's not a vaccine that stops disease, but rather it's vaccination of a population. And so the questions continue. How do we produce, distribute, and administer a vaccine at scale? How will we choose who gets vaccinated first? How do we feel safe as clinicians about such a rapidly produced and briefly studied vaccine? And how do we most effectively counsel our patients and our friends, our family and our communities about COVID-19 vaccines? Ultimately, I think we all want to know if a vaccine will have a meaningful impact on the course of the pandemic and how much vaccines will be a part of returning to some pre-COVID normalcy in our lifestyle. Every month when we do this speaker series, at least several of you ask, when will it end? We won't have the answers to this question for a long time, but we will get a taste of what the very cutting edge of thinking and knowledge is with our speakers today. So our session will begin with a presentation from Dr. Susan Bookbinder, giving us an overview of COVID-19 vaccine development, followed by Dr. Arlene Brown talking about equity issues and vaccine acceptance, among other things. And finally, we'll hear from state leaders, Drs. Erica Pond and Ms. Tricia Blocker, about preparations going on at the state level. Following our presentations will be a question and answer session. Please remember to submit any questions that you may have throughout the presentation by using the question box in the control panel located at the right-hand side of your screen. We'll go over questions at the end of the presentation. And now I am honored to turn my time over to Susan Bookbinder, who's a physician, the director of Bridge HIV at the San Francisco Department of Public Health. She's also a clinical professor of medicine and epidemiology at UCSF, and she practices clinically at Zuckerberg San Francisco General Hospital. Thank you.
Thanks so much. I'm going to be talking about COVID vaccines, where we're going and how we'll get there. Next slide, please. And I thought I would just start with yesterday's headline, which is Pfizer's early data shows vaccine is more than 90% effective. So that was really exciting news, but we'll be talking through the course of this talk about what it means both for this vaccine as well as other vaccines. Next slide, please. So what is it that a COVID vaccine could do? Well, it could benefit the individual by either reducing the severity of disease or even preventing infection. But we also want it to benefit the community so that it would reduce transmission and lead to healthier communities. Next slide, please. So this is a graphic of herd immunity that's received a lot of attention. If we have a naive population at the top, the blue people are susceptible to infection. And you can see that once somebody becomes infected, they spread to multiple other people who then go on and spread to multiple other people. And therefore, you end up getting spread throughout a community. On the bottom row is what happens with herd immunity, where much of the transmission is blocked. Some transmission will still occur with susceptibles, but if you look at the bottom right corner, many people are still indirectly protected because of the number of people who are immune in the population. That's what we hope a vaccine will do. Next slide, please. So this is a picture of the SARS-CoV-2, the virus that causes COVID, and it's called a coronavirus because it has this crown of spike proteins around its surface. The three-dimensional structure is shown on the right. Next slide, please. And this is a picture of the virus shown on the left and a human cell on the right. And what happens is this spike protein that's sticking out on the left serves as a key that enters the lock, which is this human ACE2 receptor, and unlocks the cell so that the virus can enter. Next slide, please. This is the spike protein entering the ACE2 receptor so that it could actually infect the cell. Next slide, please. But if you have antibodies, these Y-shaped configuration Y-shaped items on the slide, you can see that it blocks the spike protein from attaching to the ACE2 receptor and therefore prevents transmission of coronavirus, of the SARS-CoV-2 infection. Next slide, please. So people have talked about the accelerated timeline, and what I just want to show you is that we have generally 3 stages of clinical trials. Phase 1 is to test safety, tolerability, and get early immune responses. Phase 2 is digging deeper into the immune responses that are seen with different dosing schedules, different doses administered. And then phase 3 is where we actually ask whether or not the vaccine will provide protection from infection or disease. What's happened here with SARS-CoV-2 vaccines is that no phases are being skipped, but the timeline for these phases has been compressed. Next slide, please. So on the top of this diagram, what you have is traditional vaccine development, where you've got preclinical development in animal studies. Then you go through the 3 phases of clinical development and licensure, and only after licensure do you start large-scale production. On the bottom of this figure, you can see that the clinical development timeline is compressed, where you're sometimes combining, for instance, phase 2 and 3, and large-scale production begins even before we have data on whether or not the vaccine is efficacious. That's what's happened right now with all of the vaccines that are being tested through Operation Warp Speed. They're beginning production of vaccine even before we have efficacy results available. Next slide, please. So this just shows you what an accelerated timeline this has been. On the left, you can see that January 10th was when the SARS-CoV-2 sequences were first published, and just 2 months later, the first phase 1 clinical trial started. So really unprecedented speed of development of vaccines and then getting them into the clinics. Next slide. This is a coronavirus vaccine tracker that you can find in the New York Times. It gives you up-to-date information. Right now, there are 50 vaccines that are in various stages of testing. Some are in multiple phases of testing. That's why this doesn't sum to 50. There are 6 vaccines that are approved for early or limited use in Russia and China, but that's without efficacy results available. So the Pfizer vaccine is really the first efficacy results we've seen, and those are preliminary results. Next slide, please. So let's talk about vaccine efficacy studies. Next slide. The question is, how do you test these? Because they require really large populations of people. And most of the studies are being done through the CoVPN, or the COVID-19 Prevention Network, which is a linkage of multiple NIH-sponsored networks that's through the National Institute of Allergy and Infectious Diseases. We have 3 sites here in the Bay Area, and there are others throughout California. The mission of the CoVPN is to conduct phase 3 efficacy trials to prevent infection and COVID disease, and the plan is to open 5 phase 3 vaccine efficacy trials in 2020. Next slide, please. This is a map of the CoVPN, and you can see that there are sites throughout the United States, Mexico, Puerto Rico, South America, and Africa. Next slide, please. And if you want to find out more information about the CoVPN, you can go to coronaviruspreventionnetwork.org. There's also a registry where people can sign up to participate in vaccine trials. We've had several 100,000 people sign up to date. Next slide, please. So these are the subsample of the vaccines that are currently in clinical trials, and you can see that they're using different platforms. So there are 2 mRNA vaccines. I've highlighted in red those vaccines that are going into efficacy trials in the US. The Moderna trial is already completely enrolled. The Pfizer vaccine trial is what we heard about having preliminary efficacy results from. Those are both mRNA vaccines. There are 2 vector-based vaccines that are currently in clinical trials, the AstraZeneca vaccine of a chimp adenovirus vector and the Johnson & Johnson vaccine using an Ad26, an adenovirus type 26 human vector. And then there are 2 protein-based vaccines, Novavax and Sanofi, that should be entering clinical trials later this year. Next slide, please. So what's great about doing these things through the CoVPN is that they're harmonized protocols. They use a common data and safety monitoring board so that all of the data are being looked at, but not just within, but across trials. They each are enrolling 30 to 60,000 participants. They're estimating a minimum of 60% efficacy with a lower bound of the 95% confidence interval of 30 or greater. They all have aggressive recruitment timelines and follow up for up to 2 years, but early interim analyses planned. The primary endpoint is symptomatic COVID-19 disease, with protection from infection and protection from severe disease being secondary endpoints. There's close follow-up of infected participants in all of the trials. All of the trials involve adults aged 18 and older, including the elderly, although the Pfizer trial now goes down to participants aged 12 and older. They all exclude pregnant and breastfeeding women, so we're not going to get data yet on that population. And they include people who are SARS-CoV-2 seropositive, but don't know that they've been previously infected. And the reason for that is that when we roll out the vaccine, it's likely that we will not be testing people for antibodies first and screening them. So we want an expanded safety database, but also an efficacy database, because it's possible that natural infection doesn't provide long-lasting immunity. There are also plans to harmonize the laboratory assays so that we can do bridging studies to other populations. Next slide, please. So this is the timeline for the interim analyses. The first interim analysis took place with 90 infections in the Pfizer trial. These are the Pfizer trial is not being done through the CoVPN. This is the 5 other trials that are being done through the CoVPN. And you can see that they're staggered in terms of when we expect early interim results with 50 infections seen, all the way up to 150 infections seen, which is what most of the studies are powered on. Next slide, please. So what is an emergency use authorization? That's what Pfizer has said that they might file for one by the 3rd week of November. It allows the use of unapproved medical products to diagnose, treat, or prevent serious or life-threatening diseases when certain criteria are met. Next. And the criteria for the COVID-19 vaccine that FDA has stated is that they want to see a minimum vaccine efficacy of 50% with a lower bound of the 95% confidence interval of greater than 30%. They want to see a median of 2 months of follow-up after the full vaccination series. So that means at least half of the participants will have achieved 2 months after their last vaccination, and that's what Pfizer is waiting for in order to file for an EUA. And they want to see a minimum 5 cases of severe COVID disease in placebo recipients. Next slide, please. So let's talk about some of the challenges. Next slide. The first question is, will we have enough data? We want to be sure that we have enough data to even determine that there's that there's protection against symptomatic COVID-19 infection. We've seen that now with the Pfizer vaccine with even an early interim analysis, although they're planning to follow people through the 154 endpoints that they're expecting. The question will be, will we have enough data to evaluate severe disease? Particularly if we stop at about 50 endpoints, then only 5 cases would likely to be severe, which is potentially enough for an EUA, but doesn't really give us a lot of information about protection against. What we're really looking for is to provide protection against severe disease. If you wait another 6 to 8 weeks, you can get to 150 COVID infections, depending on the rate of accrual of infections in the placebo arm. And we expect then that we might see 15 severe endpoints, so that we would start to get some bit of a handle on whether or not we're providing protection against severe disease. Next slide, please. So the estimated supply, these data come from an earlier estimate earlier this fall from a CDC conference where they were saying that they would have about 45 million doses of these 2 vaccines. Pfizer did say that they would have 50 million doses of their vaccine available by the end of the year. Next slide. But you can see that these are some of the priority populations and the size of the priority populations. It sums to about 250 million. If there are 2 doses of vaccine that are required, we would need actually 500 million doses in order to vaccinate these priority populations. So you can see that it's going to take some time before we build up enough supply to actually be able to vaccinate all of the people that need vaccination. Next slide. There are also challenges with vaccine administration. So with 2-dose regimens, we need to track which vaccine was administered because they're not interchangeable. The good news is that all of the vaccines are really focused on this spike protein, so that good news in one vaccine may mean good news in another, but they're still not interchangeable. You can't give dose 1 of one vaccine and dose 2 of a different vaccine. They have different cold chain requirements. In particular, the Pfizer vaccine requires minus 70 degrees Celsius, which is minus 94 degrees Fahrenheit temperature. So it's an ultra cold freezer that is required. Their efficacy and safety profiles may be different in different populations. So for instance, one of the vaccines may end up working better in an elderly population. We need to determine when we're going to be able to vaccinate children and pregnant women. And although we need high throughput, we'll need to be able to also do socially distanced administration. Next slide, please. Another challenge, anti-vaccine movement. And that's true both generally, and next slide. There's some that is specific to the COVID vaccines. Next slide. These are data from a survey that was done in May of 2020 and then in September of 2020. And what you can see is that the overall proportion of people who say that they would be definitely or probably willing to get a vaccine for COVID-19 if one were available today has gone down over time. And that's true by gender, it's true by race, ethnicity, by age, and by education. Now, our hope is that as you get to better data on the high level of efficacy of a vaccine, which we've seen at least preliminarily from the Pfizer vaccine. And once we have more safety data, that people will actually be willing to get a vaccine. But there are concerns about it, and some people feel that the process has been rushed and they're concerned about safety and efficacy. Next slide, please. The other question is, how will we achieve herd immunity that I described early in this talk? And this is data from a modeling study that suggested if we had a vaccine that was 80% effective, we would still need at least 82% of the susceptible US population to be vaccinated to achieve the herd immunity threshold. That suggests that we're going to, even with a highly effective vaccine, we're going to need a majority of people to be vaccinated in order to achieve herd immunity. We might do better if susceptibility and transmissibility is not homogeneous throughout a population, but maybe heterogeneous. And if we combine it with things like masking, then you need an even lower threshold of people to get vaccinated. But this just suggests that it's not going to be tomorrow that people can throw their masks away and get rid of social distancing. Next slide. So there are a number of unanswered questions. Ensuring data are collected on populations most heavily impacted is going to be important because we're going to want people to feel comfortable getting the vaccine. We have questions about what's going to happen to the vaccine trials currently underway once an EUA is issued. Both within that trial, will the blind be able to be maintained so that we can look at long-term effects of the vaccine, as well as other vaccine trials? Will they end up being able to continue, or will they end up being head-to-head comparisons of vaccine A against vaccine B? And when will immunobridging studies be done with other populations, such as children? The rollout of vaccines locally, nationally, and globally, we've talked about some of the challenges. We've got to talk about who's going to be prioritized. Will they be willing to get the vaccine? And how many people are we going to need to vaccinate in order to achieve herd immunity? And then we're going to need to be able to collect post-marketing safety and effectiveness data. So next slide. This is my last slide, I believe. A summary: vaccine trials have been accelerated, but no steps are being skipped. There are 50 vaccine candidates currently being tested in clinical trials. We'll face multiple challenges in interpreting early trial results and in early distribution of vaccines. And there's substantial vaccine hesitancy about receiving a COVID vaccine, but a substantial proportion of the population will need to receive an effective vaccine in order to achieve herd immunity. So thanks very much, and I look forward to the question session and answer session at the end. Thank you.
Thank you so much, Dr. Bookbinder. Wow, that was an incredibly dense and super informative presentation. And I'm looking forward to some time to process it all. And just in time for me to begin to process that, we have some more really wonderful information. Next up is Dr. Arlene Brown, who's a professor of medicine at the Geffen School of Medicine at UCLA. And she's the co-leader of the Community Engagement and Research Program at UCLA's Clinical and Translational Research Institute, and has been brought into this COVID-19 world with a very exciting project that she's going to tell us about. So thank you so much for being here, Dr. Brown.
Thank you. Thank you so much for inviting me to speak today. So I'm going to talk today about a new project that's just developing, and it's called Shared Trust Organized Partner, the COVID-19 California Alliance, or Stop COVID-19 CA. And the focus of this project is to try to understand and reduce disparities in COVID-19, both disparities in the rates at which people are acquiring the disease, but also in the disparities in understanding of the disease as well. Next slide, please. Next slide. Thank you. So first I'm going to talk about racial and ethnic disparities in COVID, then a little bit on Operation Warp Speed, but Dr. Bookbinder did a wonderful job of describing that. And then some of the national and state programs designed to reduce COVID-19 disparities. And then finally, leave you with some resources for addressing COVID-19 in your practices. Next slide. Thank you. So many of you know the data on this slide well. There are profound disparities in COVID among American Indian, African American, and Latinx communities. The case rates are higher, anywhere from 2.6 to 2.8 times that of whites, much higher rates of hospitalizations, and unfortunately many more deaths in these communities. Next slide, please. This slide's important partly because of where the inflection points are. As you can see, for whites, there is a steady increase until about 80, and at 80, there's a spike in cases per 10,000. But where you see dramatic differences are for African Americans and Latinos, where the inflection point comes much earlier, in the teens or early 20s. Next slide, please. As you know, Operation Warp Speed is an attempt to develop and implement a safe, effective vaccine for COVID-19 as quickly as possible. It's mobilized the existing clinical infrastructure for various clinical trials. And as Dr. Bookbinder said, there's no skipping of steps. There are many vaccines in development, including multiple phase 3 vaccine trials. Next slide, please. One problem with the current approach to vaccine development is the lack of representation in clinical trials. Although African Americans make up 13% of the US population historically, they've made up 5% or less of clinical trial participants. It's even more distressing for Latinos, who make up 17% of the US population, but only 1% of clinical trial participants. There's also a fair amount of heterogeneity in terms of the types of trials. So among NIH-funded clinical research, there is some representation of minorities that reflects the proportion in the community as a whole, in the population as a whole. However, there's a much lower representation of minority populations in industry-funded trials. Next slide, please. And this actually was borne out in early results from the Moderna trial. So Moderna is one of the earlier vaccine trials. They observed very low enrollment of African Americans, Latinos, and Native American participants by private contractors. And then in response, Moderna slowed enrollment. They actually then turned to academic centers with a history of working with minority communities. And they saw an increase in both the number of the proportion of minority populations, but also they changed their focus for their recruitment and retention efforts. It also was associated with increased transparency. So what you're seeing here are actually daily reports that include key demographic features of the participants enrolled. This is a snapshot from July 27th to August 23rd. Next slide, please. And what you see here goes out to October 21st. And it's of these numbers and these graphics are available on the Moderna website. Next slide, please. It's critical that there be diversity in the COVID-19 clinical trials. There is a huge amount of mistrust across the population as a whole, as was described earlier, but this mistrust is magnified in communities of color. There's a lack of coordination at the national level that has hampered the ability to create a harmonized evidence-based set of recommendations. And I think in communities of color, they have responded more negatively to this discoordination. There's also widespread misinformation that's layered on this deeply rooted mistrust. As the vaccine trials have proceeded, rather than have more interest in taking the vaccine, what we've seen is increased vaccine hesitancy. So this was about 25% in June, rose to about 35% in August, and about 50% in October. And it just really speaks to the importance of having key, well-informed national messages for engaging diverse communities. In order to have people take up the vaccine, they have to have a sense that this is a vaccine that will work for them. And it's a function of both being clear on who was involved in the trials, but also making sure that people understand that they are good candidates for the vaccine as well. Next slide, please. So what I'm going to describe is an effort by the NIH, the Community Engagement Alliance, or SEAL program. This was developed by NHLBI and our National Heart, Lung, Blood Institute and NIMHD, National Institute for Minority Health and Health Disparities, to really try to counter the mistrust that was being observed in communities across the board, and to enhance participation in COVID vaccine trials. Next slide, please. So the objectives of the overarching SEAL initiative are first to conduct urgent community engaged research and outreach that's focused on COVID-19 awareness and education. And it's really to counter the misinformation and mistrust. The second objective is to promote and facilitate the inclusion of diverse racial and ethnic populations in the clinical trials for the prevention, vaccine, and therapeutics trials. In order particularly to have representation of those who have been disproportionately affected by the disease. The next slide, please. These are the 11 states where the SEAL initiative is located. California is one of them. And these were all sites that over the summer and early fall had very large upturns in the number of COVID cases and COVID-related mortality. Next slide, please. our group put in an application for this, and we have a statewide California initiative, the Stop COVID-19 CA project. The program goals are to work with a range of community stakeholders to basically, first off, identify unique barriers and facilitators to knowledge about COVID-19, the risk testing and prevention. Also, to try to understand feasibility and acceptability of participation in the vaccine trials, and finally, and most importantly, uptake of an approved vaccine and once it's available, particularly for high-risk communities across California. And we're doing this in a process where we're co-developing the solutions with communities and really trying to focus on culturally and linguistically tailored strategies to address each of the 3 barriers described earlier. Our final goal is to develop and to identify best practices for training and deploying community academic partner teams. We really want both trusted messages and trusted messengers who can deliver those descriptions. Next slide, please. So these are the 11 sites across the state. They're all academic centers with very strong community networks. California as a whole has the largest number of COVID cases and very high mortality. And we felt it was really important not just to have representation across the state, but also to make sure that that representation included the communities that were most affected. Next slide, please. These are just a list of the principal investigators at each of our sites. And in the next slide, the next slide is a long list that describes all our partners. Right now, we started off with about over 70 active community partnerships across California, and this has expanded. And they range from folks up in Northern California at Davis down to the Imperial Valley. Next slide, please. Our site projects are really local. We felt that it was important to have local solutions to local concerns. And so the focus, though, is on information needs, strategies to enhance trial participation for those who were interested, and also to understand and address vaccine hesitancy. So we're working with those who can provide trusted education and outreach, including community health workers, community organizations, faith-based organizations, local media, and then doing town halls, health fairs, mostly virtual health fairs right now, and listening sessions. A lot of qualitative work is being done to try to understand barriers in multi-ethnic communities. And then we're doing a lot of capacity building, training community health workers on COVID-19 prevention strategies, on the vaccine trials, on what a vaccine is and does. And we're really working to make sure that the education that's being provided is tailored to the local populations. We're also working locally with many communities doing needs assessments and surveys. And then several of our sites are working very closely and collaboratively with the clinical trials, so that the clinical trials are getting input from community members, providing insights into their concerns about participating in the trials, and also pragmatic issues like the difficulty of getting transportation or childcare if you're participating in a trial, getting time off from work, things like that. Our goal is to reach many different populations listed here, including African American, Latinx, Native Hawaiian and Pacific Islanders, South Asian communities, but also different categories of workers, essential workers, immigrant communities, LGBTQ, and monolingual Spanish communities. Next slide, please. We also have several statewide activities. We're working with the California Health Interview Survey, or CHIS. CHIS, as many of you know, is a statewide survey conducted in English, Spanish, Cantonese, Mandarin, Korean, Tagalog, and Vietnamese. They actually launched a COVID survey back in March that went through September. We'll be working with them to create a dashboard for all the communities involved in our study. And we're also working with them on a project that they had designed and now are able to implement in collaboration with us, looking at discrimination around COVID in Asian, Native Hawaiian, and Pacific Islander populations. We're also doing ethnic media outreach outreach, which is another cross-site activity, training and resources for varied ethnic media statewide to raise awareness about COVID, risks and attitudes, to talk to people who have been affected by COVID personally or family members, but also to talk to people who've participated in clinical trials, to say that there are people who may look like the diverse members of the California populace who are participating in the trials. And then we're actually doing a lot of community academic co-development, tailoring, and sharing of intervention. So there's a lot of sharing of lessons learned across the 11 sites within California, and we're also working very collaboratively with the other 11 states involved in this process. Next slide, please. So one thing I wanted to highlight is that there are many resources out there, and we've tried to kind of curate some of the ones that we think are most useful. So we have a set of resources that are available through the California Medical Association and also on our Stop COVID-19 website. These are the general communications, workplace guidance. Many of them are available in multiple languages. Next slide, please. Nope. And so I've highlighted here some of the ones that are available in several languages. There's the CDC COVID Communication Toolkit for limited English proficient populations, and the list here just shows the number of languages it's available in. OSHA has workplace guidance, again, available in multiple languages. HHS has resources on COVID-19 and vaccine trials. And then the CDC has a health equity page that has a number of different materials that might be useful. On the provider side, if you click to the next slide, please. There are many resources available as well. So there's some are physician-focused materials on how to talk to patients about their risk of COVID, how to discuss once someone has COVID, what to expect. The other things that they have are materials on testing and tracing. Johns Hopkins, for example, has a free course on COVID-19 and contact tracing. And then there's a fair amount of information out there on COVID-19 vaccine readiness and communication. So we have, most of these are available for you through, as I mentioned, the California Medical Association and on our website. So I'm going to stop there. I want to thank you for your attention and happy to take questions later.
Thank you so much, Dr. Brown. Really such important work, and I'm really glad to have the details of how that's going on in our state. Such important issues that we face, and I look forward to asking questions about some of the details of that in a minute. So our final presentation today is from Dr. Erica Pan, who is the California State Epidemiologist and the Deputy Director of the California Department of Public Health, Center of Infectious Diseases, and also Ms. Tricia Blocker, who's the Deputy Director of the California Department of Public Health Emergency Preparedness Office. Both of their names say Tricia Blocker, but we will let them introduce themselves separately, and we're grateful to have you here today. Thanks.
Great, thank you, Kim. Can you hear me? I will go ahead and start, and then I will turn it over in a little bit to my colleague, to Tricia. Thank you so much for welcoming us back to CMA Grand Rounds. And then the other sort of brief background on myself is that I'm a pediatric infectious disease doctor. So a lot of the vaccine area is a big interest and passion of mine as well. So we're here today to tell you more about what we're doing at the state level about this sort of nitty-gritty of how we're planning to actually distribute vaccine here in California. You've got a lot of other great background on the vaccines themselves. So on a big picture level, we've assembled a broader vaccine task force, and this has everything from immunization experts, emergency planners, logistics, communications, and external outreach coordination are the different arms of our task force. And that task force is across our state government and a lot of the different departments, everything from the health department and our Health and Human Services Agency, our Office of Emergency Services, Social Services, just a lot of our other important key partners within the state government, and then being able to, again, have an emphasis on engaging stakeholders. And then, of course, a huge, let's see, next slide, please. So a huge first up goal is, and again, you've gotten a great background on this, but we at the state level also want to make sure that we are evaluating efficacy and safety of the vaccine. We'll acknowledge some of this lays with a lot of the background you've already seen about just mistrust of the vaccine and when certain promises were made, if there was going to be any mistrust about the process. So again, we wanted to establish a scientific safety review work group. And this is a group of immunization and public health physician scientists. We have local, state, and federally and academics that are nationally recognized, that are actually people that are already staying abreast, like people here in this group, staying abreast of vaccine candidates and trials, and also helping to, at the state level, independently review the evidence as being put before all of us. We actually recently also had the opportunity to partner with the states of Washington, Oregon, and Nevada. So they have each added a couple members each to help be part of our process, and they'll bring that information back to their own states as well as they plan and distribute vaccine. So this, the most common question that's come up around this is this going to delay distribution of vaccine in California? And we absolutely intend for it to not delay vaccine. We are lucky enough and intentionally added a lot of people on this particular work group that are already on either the FDA VRBAC committee or the ACIP work group. And then we have other people that are going to really help us think about equity and allocation, just like Dr. Brown. So we really want to make sure at the local level, again, we're so lucky in California to have so many rich resources as you're seeing before us, and being able to have that group advise us here at the state as well. And then again, another theme that you just heard throughout these presentations is that we need a community vaccine advisory committee as well. So we want that to be able to have a lot of different stakeholders working with us to provide input and feedback in these key policy decisions, and also be trusted messengers to the diverse communities. And again, it's really great to be able to partner with others across the state on this, which is a good segue to the fact that we also have a drafting guidelines work group. This work group is focusing on a prioritization framework allocation plan, and we are lucky enough that Dr. Brown is actually a member of that work group and is helping us think through all the issues she's presented to you about how she's already really vetted and what's happening statewide and nationally in this area. So another group of immunization and public health experts, and including ethicists, long-term care facilities representatives, and other stakeholders that are going to, again, help us develop the prioritization framework for COVID-19 vaccine allocation. This is going to be especially hard when we had in the beginning when we have limited supplies, which we'll talk about in a little bit. And all of that information will then be presented to the advisory committee, which has an even larger group of stakeholders to then provide, again, feedback and input, and then advise the state of California. So this entire team and all these work groups are already working really hard to ensure plans are in place to be ready to vaccinate in California once it's available. Really overarching principles are equity in the allocation and distribution, working closely with our local health departments and other stakeholders to ensure that equitable access occurs. And we're going to be leveraging data, continue to have data and science drive our response here in California. So looking at everything from our levels of disease transmission and our blueprint, the geography, other vulnerability indices. As many of you have seen, we have a health equity metric using the Healthy Places Index, and that's something else we look at closely in California as we think about where our disproportionately impacted populations are and where we need to prioritize our response. So, and again, just it's going to be said over and over, and as already mentioned, but we know that one of our biggest challenges around this is employing an effective communications campaign and being able to employ trust and get public trust. So we need to tailor our messages. Again, just as Dr. Brown was emphasizing a lot of different tools and resources around that, and be sure we can reach diverse populations. So we'll be looking at robust research in that area as well, and hoping to understand other attitudes and beliefs across the state in different populations and occupations. And again, having all of our response guided by safety, transparency, and equity. Next slide. So you've heard a little bit about Operation Warp Speed. I think here we'll just mention that we were one of the 5 jurisdictions initially engaged in these vaccination micro-planning sessions with the CDC and the Department of Defense. And these were sort of interactive sessions where they could also actually learn a lot from California and what we've already done. So our experience is wide in mass vaccination efforts, both urgent and routine. Many of you as well were part of the 2009 H1N1 pandemic, and that was actually the largest mass vaccination effort in recent years that we all did together. So we have a lot of experience on that front. A lot of the themes are the same. I'll talk later about some of the differences. And then many of you may remember the large outbreaks in the homeless with hepatitis A, and there was a lot of distribution of vaccine in really non-traditional settings. So getting out into encampments and really out in the field providing Hep A vaccine. So that was also another mass vaccination effort that really happened statewide, even outside of where the actual outbreak was happening. Every year, of course, we distribute a lot of flu vaccine, vaccines for children program. There's actually a vaccine for adults program as well. So there's a lot of infrastructure already here in California that we use routinely every year. As far as other infrastructure related to that, we have general fund money that's been in the general fund at the state level for pandemic flu planning for years, and that gives a little bit of money in each local jurisdiction that the local health departments have been receiving that money and planning, for pandemics for many years. And then also the grant funding for other immunization grants and allocation and what we call medical countermeasure planning. So again, planning for vaccines and other medical therapies at state and local levels. So we also use all of that background as a history of utilizing our key partners and working and collaborating with other stakeholders together. Next slide. So speaking more focused on what our infrastructure is here, we every year over about a 3 to 4 month flu season span, there are about 19 million flu vaccine doses were given in 2018-19, and it varies around there, but just again to say millions of doses are distributed through our infrastructure every season. And then of course we have high immunization rates, thankfully, here in California for children. They're lower for adults, but tens of millions of routine vaccines are given every year. Most of those doses are administered in clinical settings. Over 90% are in settings like your clinics and hospitals and pharmacies and other medical settings. And our local health departments are a key safety net. So less than 10% though of seasonal flu doses are actually administered by local health departments. Again, most of it is in those clinical settings. And we have though proven, again, with local health departments that there's an ability to provide non-traditional vaccines, non-traditional settings, and provide vaccines in settings like schools, mass vaccination clinics, homeless encampments, and have that surge capacity during pandemics or outbreaks or other urgencies. We've also seen during meningococcal outbreaks, local health departments have provided meningococcal vaccine in various settings, and we had to double the routine administered doses during 2009's H1N1 pandemic. Next slide. So this is a graphic that you may see again in other settings, but just trying to think as we think about planning in the different phases of when vaccine is going to be available and how much. So in the very beginning, we would think it's going to be a very limited supply. I'll get to some nitty-gritty numbers in a bit, but in the beginning, when we have a constrained supply, it's going to be a scarce resource, and we're going to have highly targeted administration that's going to be with those initial doses, and we'll try to get some coverage in priority populations. So in the national allocation framework, example populations are healthcare providers like yourself, our first responders, also other people with medical conditions and the elderly who are most vulnerable. But again, what we need to do in the state and then at the local level is really think carefully about what are those actual numbers of healthcare providers and which kinds are they and who is going to be the highest priority. And that's where people like Dr. Brown and other partners are going to help us really frame that out for the state and figure out that nitty-gritty and then help guide the local health departments to do that equally. And then in that next phase, there's going to be increasing numbers of doses available, and hopefully there will be sufficient supply to meet demand. And as we'll say over and over again, we want to make sure there is a demand. As that supply increases, we'll increase access. We'll broaden the network where the vaccine will be distributed, again, potentially including some surge capacity. So this is where non-healthcare critical workers are in the priority groups, other people in congregate settings, and all other older adults. And then we'll also, other priority populations are going to be young adults and children once there's a pediatric approved vaccine, and other critical workers. And then, I think as we sort of reach a peak of mass vaccination, we'll be continuing to vaccine and it'll become a routine strategy over time. So at some point we may have excess supply, but continue to have a broad administration network. We'll probably wrap more into our traditional networks for increased access to vaccine and when all others would get vaccinated. Next slide. So this is just to kind of give you an outline. This was given to us probably end of the summer from the federal level, trying to give us an estimate of how many doses would be available nationwide. So originally they said by the end of October that there could be 2 different vaccines that might be approved and available. But in the beginning, there might only be 3 million doses in the very, very beginning nationwide again, and then 20 to 30 million doses you know, another month after that, and then maybe eventually after that, you know, a much higher number. And then this is just to illustrate again too that we have this possibility of having 2 or more different vaccines that might be approved that we need to distribute that might have really different requirements as far as storage and distribution. So the ultra cold is going to be a big issue, and Tricia will talk to you a little bit more about our planning for that. And then other just you know, logistics that we need to figure out, and also different vaccines might have different doses as far as when the first and second dose are required or just 1 dose. So those are all sort of the logistics we're also juggling as we think about planning ahead for the state. Next slide. I think the other thing I would mention about that last one is the numbers of if you translate that to California, just looking quickly at what that translates to, we would only get, like if there were, actually if you go back 1 slide real quick. So if we only get, for example, 20 to 30 million doses nationally, then California would get about 12% of that share, and that would only be like 2.8 to 3.9 million, 2 to 4 million, 3 to 4 million about doses. And again, as was just mentioned, we have 40 million people in this state. So, and then as there are more vaccines available, you know, if nationwide it's in the 40 million range, we'd only get about 4.8 million doses. So again, figuring out how to allocate that across the state in an equitable way. And then early after that, we'd have more availability. Okay, next slide. So again, just sort of reflecting on what we learned in 2009, what we know now and what we don't know. So we did learn in 2009 there were a lot of things that we were told when vaccine was coming. Many of us stood up clinics, you know, when we thought it was coming in September, and then it really didn't come until October. So we just have to be really prepared for a moving target as far as when that timing is going to be available and how much is going to arrive. The distribution from the federal government is going to happen directly to vaccinators as it's approved by the state, but the distribution will happen directly. So the federal government will make these allocations to the states, and the formula has not been announced yet, but in the past it was a population-based percentage. And then the state helps make allocations to the local health jurisdictions. So that will depend on which phase we're in of those 3 phases I just showed you, who the priority populations are, and that allocation formula. All of those are things that the allocation drafting group are going to work on for us. And then the local health departments will then allocate that to providers based on guidance from us. The providers, then you all can submit your orders, and then we would approve your orders. And then the federal government via a central distributor will be getting those directly to you as the provider. And then redistribution may be required, but we would also need to approve that at the state level if there's movement around a vaccine to meet demand, if there's sort of moving around in different, for different vaccinators. It's going to be more complex than 2009 because, you know, we know so much more now about asymptomatic transmission, and, you know, we didn't have to do these mass vaccination clinics in 2009 with physical distancing. We didn't have to have everyone wearing masks. So that's just going to make these mass vaccination clinics much slower. You know, a lot of the emphasis in planning for mass vaccination is trying to get people through quickly, but if your lines are 6 feet apart for each individual, it's just going to take us a lot longer to do it than a lot of our prior mass vaccination planning. So that's a challenge that we're working through and the locals are working through. You know, I think some things that are helpful about where we are now in this pandemic is a lot of mass testing is happening. So I think there's a lot of lessons learned and a lot of models that we're all looking at as far as having drive-through clinics. A lot of vaccines are happening now anyway, flu vaccine and other vaccines. Many of you as providers are providing in drive-through clinics, and that very well may be how we do this and with certain providers. And again, we're really hoping all of you, and we are encouraging as well, flu vaccination as a dry run to distribute vaccine. So, and again, just to continue to emphasize how important public trust is, more than ever during this really divisive time in our nation, we have to tailor our message to a lot of different key partners. And it was already mentioned, but the latest statistic is about half of the people won't vaccinate even when a vaccine is available. We know about vaccine hesitancy and again about a lot of mistrust that Dr. Brown has already mentioned. I alluded to the politicization of this as well. It is really challenging. And it's going to be interesting again during these different phases. In the beginning, when the resources are very scarce, there may be high demand, and our messaging may be really different because we need to make sure everyone sort of can support the way we are prioritizing the certain populations to get it first. And then there may be less demand as there's more widespread availability, but really wanting to get our population to a level that will help protect all of us. So all of that, and just knowing that like other parts of this pandemic, we do a lot of our planning and resource allocation based on jurisdictional lines, but we know that a lot of the needs and the disease itself doesn't necessarily follow jurisdictional lines. So those are all things we want to keep in mind as we're planning. And then also think about our long-term needs for broad distribution. So those are all things, again, we have a lot under our belt as far as our experience, both from a prior vaccination infrastructure and distribution, and just even over the 11 months that we've experienced this pandemic so far. So with that, I will turn it over to Tricia Blocker to tell you more about some of our operational logistics planning around vaccine.
Great, thank you, Dr. Fun. So another significant effort we have underway right now is around our IT system, and to really ensure that it's ready and ready for the capacity and the load that it's going to need when we get to the larger vaccination stages. We're working on an end-to-end solution for both the registration, the reporting, the tracking, ordering, the adverse events, and also just the reporting that we'll be able to do across the state. So the goal is to have real-time status of where that vaccine is, both when it leaves the manufacturer, throughout the distribution, all the way to when it's administered into people. That information is going to be fed back to CDC, and it really helps the federal government allocate doses to the states, but also for us to be able to move doses around if needed and really make sure we've got vaccine in the places it needs to be. Our team's working to make sure that this end-to-end solution is nimble, it's flexible, it does leverage current systems that we have, but we're also working on procuring additional systems to really make it a seamless operation. This is very different than previous, where the CDC has a lot of rigid and extensive data requirements. So we're just really working through this process right now. We've got two different distinct phases that we're working through. The first is to make sure we're ready any day now, for a vaccine to arrive. So we've got processes in place to ensure that both on the technical infrastructure side, but also on the manual data entry side. And what we'll eventually be doing is working towards more automation and all of this on the back end, of course, to really make sure this process is in place. So I know some of you are familiar with CARE, and just emphasizing the fact that we're really building out the front end to help with all of the ordering and tracking purposes. So we did just open our provider enrollment registration piece to our local health departments last week. So they're testing the provider enrollment side, providing feedback to us, and really working through if there's any bugs to work out. So we'll be opening limited enrollment for the phase 1A providers starting next week, and that's going to be the larger health systems and others, and that guidance should be coming out very soon, and working just closely with our local health departments on enrolling providers systematically, so we're able to very efficiently and quickly get out vaccine should it become available in a couple weeks as we're planning towards. So next slide, please. And as others have mentioned, there are a lot of unknowns, and we also have a lot of assumptions that continuously change. So we're staying nimble and flexible in our planning, but also really working towards, as Dr. Pond mentioned, being ready for the second that doses are available. So you know, one of those unknowns is just not knowing which vaccine will be approved. It's seemingly getting a little bit more clear as every day, but you know, there's a lot of different planning assumptions depending on the vaccine. The ultra low vaccine that is sort of further ahead right now presents very different challenges in terms of equity and storage and handling than some of the more traditional vaccine types. So what we're doing right now for that is focusing on the drafting work group that Dr. Pond mentioned, is to really enumerate and subcategorize the populations and to really make sure that local health departments and providers have very clear guidance of which population group is in which phase, and to systematically be able to work through that. Once we have that list developed, we'll be working on who the traditional vaccinators are for those populations, and really make sure that we've got that plan outlined for local health departments. We are unsure of how much vaccine will be available and the timing, of course. So as we've mentioned, we've planned all along since April for readiness in November, and utilizing our traditional immunization structure, and then on the back end really working towards what the larger infrastructure is going to look like. In terms of the ultra low cold storage, we've been working very hard on developing multiple scenarios across the state in case that becomes the only vaccine that is available. We've been assessing dry ice vendors and looking to a hub and spoke model that counties will be able to employ to refill the shipping containers. We're working on backup plans for ultra low cold freezers placed strategically across the state, and also to work with some maybe underserved communities or areas where that infrastructure just is not there, so that we're able to be sure to have a system in place for all Californians. There is a challenge obviously with that vaccine, just given that the minimum order is 975 doses. So we have extensive work in place right now to figure out how redistribution might look, and have, again, the freezers and the capacity to be able to facilitate that. Next slide, please. And then another unknown just happens to be, you know, just which entities will receive allocations from the federal government. That list is becoming clearer, and then other federal programs are being introduced, such as the Long-Term Care Pharmacy Partnership Program, which was announced a couple of weeks ago. So we're planning in the event of being able to ensure that all populations will have access to vaccine in accordance to our prioritization framework, and as these and backup plans in place in case something were to fall through. I think during H1N1 we had some challenges with the ancillary supplies maybe arriving at different times than the vaccine itself. So we're working on ensuring that we've got a stockpile of ancillary supplies and those kits, as well as the pieces of supplies that don't come in the kits, such as gloves or sharps containers and other things like that. So we're working on that stockpile need, and also working on just trying to be ahead of the curve in case there are any supply chain issues. Obviously, we ran into that earlier in the pandemic with PPE. So we have a team of people dedicated to the ancillary supplies and ensuring that we've got what we need. And then, as mentioned several times, the communications campaign is going to be crucial. We are unsure what the demand will be. Even with vaccine hesitancy early on, we expect that there will be a significant amount of communication needed to really talk about why certain populations are receiving the vaccine and when that their turn will be. We've got an effort underway right now to do extensive research in diverse communities throughout California to really understand the attitudes and beliefs and really know what will motivate people to want to have the vaccine. So our communication campaign is going to be crucial, and we're doing a lot of the on the ground work right now to help inform those public messages. And then next slide. And I'll just end with, vaccine is just one tool in our tool chest. It's going to take many, many months to be able to vaccinate the public, depending on when the supplies become available. So just a reminder that our best tools we have right now are wearing a mask and continuing to physically distance, washing hands, and minimize mixing. So with that, we're looking forward to your questions.
Thank you so much, Erica and Tricia. Again, just a fact-filled and really intense presentation, and I know so much more than I did before. I'm sure we all do. Before we move on to questions, I just want to remind everyone who may have to drop off because of the timing of this, or anyone who might not have been able to be here for the first part of this speaker series at the beginning when Dr. Susan Buchbinder talked, how that we have this recorded and it will be emailed to you very, very soon. So please do watch that. We are going to move on to questions from our audience. So I've been joined by all of our guests, and there are so many questions about this, as you can imagine. Unfortunately, we probably won't be able to answer them all, but we'll do our very best. So I think I'd like to get started just with that big question, Tricia, that you just alluded to. And I don't know if Susan, maybe you can start and then we can move on to others who have other things, but maybe you can just describe the steps and then give us your best guess on a timeline to an effectively vaccinated population once there is one or more approved vaccines, since we seem to be maybe a little bit close to that now.
Yeah, so I think we are getting closer to that. The Pfizer vaccine is still going to be awaiting full accrual of the number of infections that they were anticipating in the trial, which is something like 154. But that will probably come fairly quickly. They will apply for an EUA, it sounds like, and that may be granted. So there could be something even before the end of the year or early 2021. But you've heard, they said, Pfizer now says that they are going to have 50 million doses. That only vaccinates 25 million people because you need 2 doses. So I expect that there's going to be this sequential other products coming online. And the good news, again, is that they're all directed towards the spike protein. So if one vaccine is effective, our hope is that more than one vaccine will become effective. So I'm thinking that middle to end of 2021 is when we'll start to get a substantial proportion of the population actually vaccinated.
Well, that sounds very exciting. Erica or Tricia, do you have anything, or Arlene, anything to add to that? Other thoughts or guesses? What needs to be done before this vaccine can be widely available for children? A lot of people are wondering, we're hearing they're not testing it in children now. Pfizer is down to age 12, but can you guess on a timeline for that?
I don't know the timeline for bringing children into this. What presumably is going to need to be done is that there will need to be some safety data that's collected on children. So there will need to be some trials that will enroll children that are younger. And then there will hopefully be something called immunobridging. So if we can identify what is the immune correlate, what's the immune response that really correlates with protection, we can then be sure, test to be sure that children have that same immune response, rather than doing another 30,000 to 60,000 person trial in children. We would hope to be able to do the immunobridging with a smaller trial to gather some safety data. And my hope is that that would get rolled out relatively quickly, sort of certainly in the first half of 2021 would be my hope.
And is there a sense that that might need advocacy to move that and the trials on pregnant women forward, or it sort of feels like it will just be a part of the next steps that all these companies will take?
I think it will be part of the next steps, but advocacy never hurts.
Great. Well, call out to all the pediatricians and parents and community members for that.
Yeah. And one thing I would add is that one of our sites at UC Irvine is very interested in this question, and they're trying to do some work with parents and families around willingness to participate in a vaccine trial for your child, or just to have your child vaccinated for this.
Great, thank you. So speaking of sort of willingness and these issues of trust, you know, Dr. Pan, you talked about the importance of public trust. We've all really talked about it explicitly or alluded to it. And it was interesting to see as I reviewed the questions coming in from this group that we're talking to today, how many questions are really also about trust on our side as providers. So first of all, I wonder, what do we know about healthcare provider acceptance versus hesitancy around vaccines? Is there any data on that right now?
You know, one of my colleagues, I think I did hear about a survey, but I don't remember what the results were. I don't know if anyone else wants to comment about healthcare providers.
I can just add that we were working on engaging in some surveys specifically of healthcare providers, an effort to really understand, you know, our attitudes and beliefs different if you're a doctor versus a nurse versus, you know, any different classification, what it looks like regionally or geographically. And so that's part of the research effort that we'll be engaging in, and hope to have some really strong results from that to engage or to inform our education and communication campaign.
Great.
I would just add too, I think it's really important. You know, we did learn with flu for sure, and just vaccine acceptance in general, that actually healthcare providers are certainly a trusted, you know, especially those of you that have strong relationships with your primary patients. And so if we don't have healthcare providers who have trust, then we really have a problem, I think, as far as then wider vaccine acceptance. So I think it's one of many trusted sort of community voices and leaders, but it's absolutely an important area. So it's great that there is the question, and I hope we can work towards that trust, which is again why we wanted to have kind of a local work groups of you know experts like people here on this panel to really inform and hopefully help reassure our California population as well.
And as we sort of really in some ways get close to feeling like we might be approaching a time when we're looking at this in a more concrete way, what is the timing of your communications campaign that you were talking about, Tricia and Dr. Pan and Dr. Brown? When do you think you'll have some really good, robust results that we can actually use as we roll out these things?
That's a great question. And from our end, you know, we basically are working this year to try to produce materials that can be shared. And we don't feel that we necessarily have to produce them. We feel like it's important to kind of curate the things that are out there and try to understand what resonates with people in different communities, what doesn't, and also modify them as needed for the communities that are most vulnerable.
I'll just echo what Dr. Brown said. There's a lot of research required right now to just really make sure that the messages we develop are tailored to each diverse and specific audience, and we want to get that right. And so that's why we're kind of working on the ground right now to understand that. CDC will also be putting out a lot of information, and we'll leverage those materials, and then just work with all of our trusted partners and stakeholders to just get it right, and then deploy it sort of systematically based on where we are in the campaign.
Mm-hmm. So we got tons of questions about this. How do we communicate to our patients about safety? So I'm just going to sort of ask each of you to respond as you would today. And then what I'd like to commit to is for the speaker series, I think we will clearly need a new session both on the logistics of this rollout and also really around the communication strategy to arm us all and help us all feel skilled. So as it becomes closer to launch, as it were. But if a patient asked any of you, is the COVID-19 vaccine safe? How would you answer, sort of knowing what you know today? And recognizing that that answer is going to be very different for the person who's in front of you. Any pearls, I guess. Dr. Buchbinder, do you want to start?
Sure. It would depend on the vaccine, but what I would try to do is say we've got data. I would try to share how much data do we have. We have data from phase 1 and 2 studies that predate the phase 3 studies. So even though, for instance, only half of the Pfizer vaccine vaccinees will have gotten will have been followed for 2 months after their second dose. So that's not a very long period of time. It's only 4 months. We do expect that most of the sort of negative reactions to vaccines may happen early after vaccination. So I would be reassured that we're not seeing anything there. And then I would go back to the phase 1 data and say, you know, X number of people, 5,000, 10,000 people have been vaccinated with this vaccine. And so far, this is what we've seen. I would want to just share with patients what it is we actually know and also what it is we don't yet know. So, and I think that more than what we don't know about safety is what we don't know and won't know for a little while is the long-term effectiveness of it.
Mm-hmm. Right. Dr. Brown, anything to add from your point of view?
I think those were fantastic points. And I think one point that many people touched on earlier that I think really resonates with a lot of the patients and the community members I've talked to is that we haven't been skipping steps. So despite the fact that they chose the name Operation Warp Speed, this is happening the way that vaccine trials generally happen, and that not only are we not skipping steps, but it's really critical to understand that we are not, there's no expectation that this is going to look different from any of the other vaccines that are out there. So we really try to emphasize to the patients and to the community members that that most of us would be willing to take this vaccine. When they ask me, I say, yes, I'd be willing to take it. And that I think it's the safest thing to do for them, particularly if they're in high risk groups. But I think it's just sort of reassurance and reiterating that we believe that it's the process is safe. And this is exactly what Anthony Fauci said. So, and what we've heard time and again is people trust Fauci, that they will say that he said, you know, I'd look at the evidence, and if the evidence suggests that this works, I would take it. So.
Great. Dr. Phan, anything to add? Oh, you're on mute.
Sorry, thanks. I think I would just add, just to layer onto that again, and actually to reiterate again, because some people have been concerned about our scientific safety work group and is that supposed to supplant this? And really, again, what we want to be able to do is reassure people that no steps were skipped, maybe some more explanation about the process. And I think the nexus of being able to have those experts help reassure us of that, and also then work with our other community stakeholders and advisory committee to help, you know, kind of translate that message. So I hope, you know, with all these efforts together, we will have, you know, more and more messages that resonate. And again, having different messengers, I think, will be really important too. But I think another thing that Dr. Brown just said that I use a lot for promoting vaccine in general is, you know, as she said, you know, I'm getting this vaccine, I'm making sure my loved ones do, you know, and this is one of the best tools we have for, you know, a really challenging situation. So I think that's what I would add to that.
Mm-hmm. And Ms. Blocker, anything else to add?
All fantastic points. I echo the same. I think we know from other public health behavior change campaigns, when we give Californians the facts and provide them with information to make informed decisions, that's the best way to ensure and to help motivate. So I think that, you know, knowing the facts and being able to speak to them is going to be really, really important. And again, the Operation Warp Speed is a challenging name, but, you know, I think when you do explain what that entails, which is basically that production started at the same time as trials, I think that goes a long way. And I've had a lot of people kind of feel a little bit more reassured once they understand what that actually means.
Mm-hmm. Great. Moving to a slightly different question, maybe for predominantly Erica and Tricia, but anyone else dive in, of course. Erica, you talked a little bit about how public health has been pulled in for other vaccine campaigns that were outside of our traditional vaccinations. Who do you anticipate in this time with that scale of vaccines needing to be administered will do most of the administration? Will public health take more of that than they have in the past? We've seen in the press things about retailers like maybe CVS or Walgreens doing a lot of these vaccines versus the traditional kind of healthcare providers.
I'll start, and then I'm sure Tricia may have more to add as well. But to your point, yes, I think other pharmacists already are doing a lot of vaccines, right? The flu vaccine sort of signs outside CVS and Walgreens, and there have been these agreements. I do think a large proportion will still happen through our normal networks, but I think there's also thinking about different settings. So even it might be traditional providers in different settings. And then, I think during H1N1, that was when we changed regulations so that EMTs and paramedics could get vaccines. So thinking about other types of healthcare providers. But I think a lot of it still will happen through there. I think, as there's probably that peak when more is coming out and there's a high demand, there definitely may be some large local health department mass vaccination. But again, in partnership, I think. And, we talk a lot in mass prophylaxis and mass vaccination planning about the push and the pull. So a lot of it is trying to push that vaccine to, traditional providers or even with things that are not as complex as vaccine distribution, working with, large corporations even too, or sometimes, but even with that, sometimes first responder organizations do their own flu vaccine planning. So there's a lot of different ways to do it creatively like that. And Tricia, you may have more to add to that.
Not much more, you did a great job.
Okay, great. And what do we know about the cost of any of these likely to be approved vaccines? And what do we know about payment structures, what maybe the federal government has made any promises about, or how that might work out? Do we know much?
We know that we're going to receive the vaccine free to us and then to the providers. And then right now we're working through sort of all of those issues around what the administration costs will be and what sort of coverage. I think we are committed to Californians not having to pay out-of-pocket costs for this, but needing to do some work on what that looks like still.
Great. Here's some sort of we probably don't know the answer to this, but maybe you can speculate a little bit. What are we learning about SARS-CoV-2 as it mutates and changes? We know that we have to take a new flu vaccine every year. Do we have any sense of how this virus is the same or different than that, and whether we might have to evolve our vaccines?
We know that it doesn't mutate in the same way as flu vaccines. So our hope is that we won't need to have, for instance, an annual SARS-CoV-2 vaccine because it's changed so much. What we don't know is how long the vaccine will last in terms of its protection. So that might require that people get revaccinated, but it's not mutating in the same way nearly as quickly as flu does.
Great. And any preliminary guesses on how long the immunity might last based on what we know, or we just really don't know at all?
We really just don't know.
Okay. So to get back to something that I alluded to or talked about at the very beginning, when we have a vaccine, I'd like to hear from each of you. How is the vaccine for COVID or several likely to have an impact on our ability to return to pre-COVID routines? We talked about, it's already been said that it's going to be a long time before a significant amount of the population is going to be vaccinated, and we'll have to use a lot of public health mitigation strategies along the way, masking and distancing, those kinds of things. But just tell your view of that story. Can we get the full population or the 89% vaccinated, and then do we get to stop doing all those things and sort of go back to a normal life? Maybe since I put Dr. Bookbinder on the spot last time, Dr. Pan, why don't you start with that, and then we'll get any other ideas that people have.
I will take a stab. I mean, I think it's a crystal ball kind of a question. I think as Susan said, we don't know how long immunity will last. I think, and then, yeah, how quickly we'll get up to having sort of what levels of people we vaccinated and then what level we need for sort of community immunity or herd immunity. So, you know, I do think and hope that, you know, this will eventually normalize into, you know, another, you know, vaccine preventable disease, that we will, you know, we will still see disease, but it will hopefully be much, much rarer at some point, and that we could eventually get back to our more normal lives. But I wish I did have that crystal ball. I mean, I'll say on the other end of it, I've been saying to people, and I think it was really helpful for expectation management that Susan said too, you know, probably not till the end of 2021 is when we'll really have more people vaccinated. And so just for our planning for response and for managing expectations, I think, you know, I think we are in this for at least another year of doing a lot of these mitigation strategies. And beyond that, you know, in COVID time, it's so hard for me to think the next month, much less just the last 8 months have been very long. But yeah, I think I don't know if I can say much beyond that next year.
Anyone else want to add to that?
I'll just say, you know, we've got 40 million people in California, and, you know, if you even think about 75% of that 30 million, if you do the math, you know, at vaccinating 350,000 people per day for 6 months, you know, that is sort of the level of how much it would take to be able to get to 75% of people receiving vaccines. So, you know, that's a significant effort over 6 months, especially when you think about, we do about 125,000 COVID tests per day. So, you know, so we're not even testing at the amount that we would need to be vaccinating. And I think that's an important perspective point of how long it could take to actually vaccinate our population.
Okay.
And 2 doses is the other thing to keep in mind too. Yeah.
Right.
Anything else to add, Arlene or Susan?
No, I think, you know, I do think it's going to take quite a while, and we may need to be particularly careful with those more vulnerable populations for an even longer period of time.
Mm-hmm. Yeah,
Right.
agreed. And you know, I think the other thing is that we've hit this new normal, and people are incredibly adaptable. And I think it's recognizing that we just have to put fail-safes and resources to help people bridge this time frame, and how to make sure that they get the things they need, despite all of the extent to which so much of our economy and so much of our social lives have been shut down.
Yeah. Well, again, I want to just extend an enormous thanks to all of you. I think that we have so many questions. We could talk to you for another hour, but I feel much more educated and actually quite hopeful about the work you're all doing, and I'm grateful that you're all on these teams. That is all the time today we have for questions, and I want to also thank all our audience for being here today, and I'm sorry we weren't able to ask every single question. We are going to have our next COVID-19 Virtual Grand Rounds webinar on Tuesday, December 8th from 12 to 1:30, and more information on that is available at covidroundsca.com. Also, just a reminder that CMA provides lots of webinars and resources on the CMA Telehealth Tipping Point project, and you can find additional information at cmadocs.org/telehealth-webinars. And then a final reminder, you will be sent a survey upon the completion of the webinar where you can attest to your attendance, and you have to do that to get your certificate, and that email that will be in follow-up will have show you how to access the recording of the webinar. So please do share widely. This information is so important for all of us as providers and again as members of our California community. And thank you everyone, and have a great day.
Thanks.